All right,
constructs.
let's start with the neurobiological data.
Sure, and this gets to, like the criteria, and these get to the Koch's postulates, which are kind of similar. So the neurobiologic data, so for example, for depression, for major psychiatric conditions, the data are very clear.
No.
I know we're going to disagree about this.
When you say things like data are very clear, that's where I feel like we'd be misleading the public. It's okay for you to say, I believe this exists, and you might want to cite it, right? Because then I can include it in the show notes, and then we can evaluate it. But I don't think you're being completely transparent when you say the data is clear when it's clearly controversial, very controversial. I'm okay with you speaking your position, but I'm very careful on this podcast by communicating things that we don't know to be true.
We would disagree about that, and that's okay. It's totally okay to disagree.
What are the biological markers then for major depressive disorder that we use to make that diagnosis?
So, those are two different things. So, to make a diagnosis is different than knowing that something is biological in nature or understanding the neurobiology. For example, most medical conditions, even if they have a biological diagnostic marker, let me back up. We don't necessarily understand the biological cause of most medical conditions, even though in many cases we have a biological marker. Say, so for example, blood pressure. I mean, there's the diagnostic marker is different than, for example, the biological cause, which isn't even totally understood. So it's just, this relationship, this is just how medicine works. We can't understand everything we're learning.
But that's a biological marker that one can evaluate in a medical practice.
Right.
What's the biological marker for depression?
But those are different, just to be clear, and I'm going to get to it. I'm just saying that just because we don't have an adequate diagnostic marker, which actually is not the case, we actually do have diagnostic markers for most conditions, they just don't reach the statistical parameters, sensitivity, specificity, all these sorts of things, aren't better than phenomenology or the DSM criteria. That's why we don't use them. But we do have, we could use any of the neurobiological markers as diagnostic markers. It's just that, again, they don't perform better than phenomenological criteria, like the DSM criteria. And then you have to consider cost and risk and those sorts of things, which are very important. And again, this is common among medicine.
But what you said, you said neurobiology.
So then what's
the consistent biological marker found in depressed individuals?
So there are many, but I think the one that most people think about or have heard about, and the one with which I'm most familiar, because this is one of my areas of research, is the monoamine hypothesis, or the monoamine markers of depression. Because obviously, also I deal with schizophrenia, so we talk about primarily dopamine and glutamate. But in depression, as we know, depression is reliably and validly related to, again, it is complicated, but lower levels of monoamines, primarily serotonin, dopamine, and to some degree.
So the whole chemical, you're kind of going to talk to me about the chemical imbalance theory of depression.
That term is used. It's the monoamine hypothesis, the lower levels of serotonin and dopamine. Again, it's a little more complicated than that, but yes, that is right.
Are you aware of the umbrella study in 2022 that was put out there?
Moncrieff.
Yeah, Joanna Moncrieff.
Sure.
I guess one of the things that is challenging to me is that the idea that depression is related to low serotonin or deficiencies in serotonin was never reliably proven up to the point of when we pushed on antidepressants, and it's never been confirmed. It has. Well, there's many people in your field who completely deny that.
So I want to be clear. I know we're disagreeing. It's okay, but I want to be clear. There's virtually this isn't controversial in the field. I understand
it's quite controversial. I have a very large platform that is now in the top 0.05% related just to these ideas. And I've had plenty of other psychiatrists on here where we've talked about the same thing. So what do you know about the Moncrieff study 2022, the umbrella study on serotonin?
I know it well. I've read it multiple times. I'm familiar with it.
Can you tell my audience about it and why you dispute it?
Sure. Well, first of all, again, I will very specifically. I will say, we look at reproducibility among studies. This is one study, again, and this was a I think that you called it in this correctly called like an umbrella review. It's actually a review of reviews. Number one. So one potential limitation of reviews of any type of review is that even though meta-analyses and systematic reviews are considered maybe the highest kind of the most rigorous type of evidence, they have to be conducted in a certain way. So, and I'm not saying that Moncrieff did not conduct hers in a certain way, but I will explain. So with meta-analysis and reviews, say say a findings, for example, low serotonin in depression. And I can explain more about what low serotonin actually means because it has more to do with serotonin receptors, but either way, and transporters. But basically, the findings of low serotonin and low dopamine, but low serotonin are primarily observed in younger people, earlier in the illness, not on medications, etc. So you have a few of those studies, but then you have a lot of studies in which, like PET studies or studies examining serotonin levels in people with depression and people who have comorbid disorders later in their illness on antidepressants. So if you put all of those together, you'll see nothing because you'll have like a handful of studies that are positive or show that finding, and then you'll have many more that don't because they weren't they were different than the other studies. That's how those things can
just to be clear about their position, they say there's no relationship. I mean, it's a complicated neurochemical that impacts the entire body.
They didn't say there's no relationship. So this is what I'm getting to. I'm going to get to her Moncrieff's specific findings. So if you look at the results explicitly say that there is a relationship. In academia and research, the most important thing is our credibility. So that's like the reliability, the validity, our ability to collect the data to put in the results and methods what we did and what we found. And then we can interpret the data in different ways, and that's totally okay. And that's what Moncrieff did. I think they very credibly reported the data, both in the methods and the results. So when I tell people, when I learned how to read research studies, and when I kind of help my mentees learn how to read research studies, I always tell them, just read the methods and the results. So if you look at the results, they say there's a relationship. And then in the discussion, they say, we're not convinced by the evidence, and the evidence to us aren't consistent. But in the actual results, they say there is a relationship, and that's specifically especially with regards to the PET or positron emission tomography data, examining relationships between serotonin, I believe this transporters and depression.
Okay, I don't want to speak for Joanna Moncrieff, but would you be willing at any point to have a discussion on the podcast with myself moderating it with the two of you, so you can just
with
Joanna Moncrieff? Yeah.
I mean, I'd be happy to. I mean, I'd be happy to. That'd be fine. I mean, but that was her. Those were her.
No, I think I think you might be misrepresenting her position, and I think the burden.
No, her position was that the data aren't consistent or convincing. But
exactly.
In the results, she reported a relationship. She mentioned it was a small, weak, but it was a relationship.
Yeah, I think and I don't want to speak for her, but I think if she was communicating this, she said, "Listen, when you identify a causal relationship, like low serotonin equals depression, and that drives the mass use of a pharmaceutical that targets that, where we don't have I can get into the long-term data problems, the concerns with this, even in acts of violence. And there's no definitive proof that anyone who has a severe major depressive disorder has deficiencies in serotonin. We can't communicate that. Like that's an invalid way of being able to describe a relationship. It's on the burden of proof is to prove definitively or clearly that there's a causal relationship because we're targeting it with a drug.